Thank you. Thank you, EBRS. It's a pleasure to be here. It's a beautiful location. I want to talk about my way in the treatment of full thickness macular hole with a fantastic tool that is the Tano scraper. I performed between September and December 2015 10 patients with an idiopathic macular hole, 4-stage, larger than more than 400 microns. The average age was 68 years, and there was a predominance of female. All patients was operated with my useful technique, and I fixed 4 goals. The first was an increase in visual acuity. Second, the study of the contrast sensitivity. And the fourth outcome was the evaluation of the ganglion cell complex. I use a standard 23 Alcon constellation technique in local anesthesia, and I use as dye the brilliant blue. As you can see in the video, I use the scraper always for create a flap of the ILM in order to grasp it with the forceps without damaging the retina and without create axonal damages. And then with Tano, I massage the border of the hole in all directions in order to get closer these borders, and also in order to create a little edema, because I think that this little edema with the contact of the gas is helpful for the closure of the hole. I, as first goal, I studied the closures of the hole. I had the closure of the hole in all the cases. Now I operated 35 patients, and I have only a failure. And I remember that the size of the hole is always larger than 400 microns. As a secondary outcome, I evaluated the increase of the visual acuity with ATDRS charts, and I had again an average gain of 4 lines. Obviously, when the outer layers of the retina are conserved, the increase of the visual acuity is better. I used also the test, the Rodenstock test, for studying the contrast sensitivity, and at 1 month and 3 months after surgery, and I obtained an increase of the contrast sensitivity, especially in the simplest cases, especially in the simplest test A and B. At the end, I evaluated the ganglion cell complex because I wanted to demonstrate that Tano scraper didn't damage the retina, and I evaluated the ganglion cell complex with a square of 8 per 8 millimeters fixed on the fovea, and I measured the mean values of the square except the fovea, because the measure in the fovea is not attainable, and I observed a reduction of the ganglion cell complex between before and the first month after surgery, but not at the 3rd month, and in this way I can say that the reduction of the ganglion cell complex is due to the reduction of the macular edema and not to the dramatic effect of the Thanos scraper. And I considered this technique very good because it increases the closure of the hole, especially in that cases in which we don't, in which we have a failure and we have no more ILM to peel and to invert. Thank you.
Thank you very much, Cindy. So I think this answers the questions about the use of the Thanos scraper. Are we allowed to do it to have like a whole membrane coming in? And it was very interesting to observe that Dr. Tassinari invert the flap and usually touch the flap afterwards. So maybe the initial thing of inducing the scrap in the ILM, and then the other continuum is easy as you do not touch the retina, you move the flap as it is inverted as well, right?
Yeah, now really I use together the technique. I use the inverted flap and I use always the Thanos scraper to massage the borders of the hole. But it's curious that after the massage, I massage a lot when the hole is very big. There is no edema. After 1 week, I have after the gas is reduced, I have no edema in the fovea.
Have you observed the nerve fiber layer edema that was, the Dunfell thing that was observed post-surgical in your technique?
No, in the treatment of a macular hole, I don't observe edema, but in membrane epiretinal, in the removal of epiretinal membranes, I can observe an increase of the edema after surgery, and instead in hole surgery, I don't see. I can see if the hole is closed or not, but I don't reveal never any edema out around the hole or around the fovea.
So this is your preferred technique of peeling the ILM, right?
Yes. Yeah.
Okay. Thank you very much. Is there any questions before moving to the flap techniques having the...
Is it possible to ask a question on the ochraplasmin talk?
Yeah, sure.
Yeah. So our experience of Rahila Zakir from London at the Western Eye Hospital, with macular hole closure, we had 8 and only 1 closed, and that was one that was less than 250 microns. The less than 400 but bigger than 250 didn't close, and in fact we saw quite a few that enlarged to larger than 500 microns after ochraplasmin, so that when we eventually went on to operate, they did poorly. They didn't close with first intention. Secondly, the side effects which you say are not serious, where you have loss of the ellipsoid, you have dyschromatopsia, you have unexplained loss of vision, I don't know how you can say that those are not serious, because we actually don't know, and the producers of ochraplasmin or the retailers of ochraplasmin don't know why they're happening. We don't know what it's doing to other layers of the eye. So when we don't know what a drug is doing, the technique yesterday described that the new recommendation for ochraplasmin is that you do it under direct view with a long needle directly on the macula. So maybe the better way to do it is, as was suggested, would save a lot of money, is just go down, do it directly under view, and inject a bubble of saline just to induce that separation. And perhaps ochraplasmin actually isn't what it was made out to be. I mean, for me personally, I think I'm waiting for a lot more information before I continue to recommend it. In the UK, it's a licensed drug, so when I see a patient who meets eligibility criteria, I'm obliged to inform them that they have an alternative to surgery. But actually, when you explain the failure rates or the success rates of injection versus surgery and the fact that it would delay surgery, most patients say, you know what, I'll just go for the surgery.
Yeah. Depends on how you sell, your product. So sometimes does. Please, please. Yeah.
Okay. I've been using heavy silicone oil for years for, highly myopic macular hole patients. But now there's a new Densron called Densron Extra. It's a little bit better. The physical properties are different than Densron 68. It can go through 25 gauge or 27 gauge. It's easier to inject than Densron 68, and it's easier to take it out. It comes out with a bubble. The main problem of using heavy silicone oil is not to put it in. It's difficult to take it out. So this new heavy silicone, which is called Densron Extra, is made different. It can go through thinner 27 gauge or 25 gauge, and it's easier to take it out. I just want to remind it.
So you have the same, the bad
I'm sorry?
reputation. The Densron had always like a bad reputation regarding the inflammatory process, the effect on the retina. So we have less of that with the Densron Extra.
I couldn't get your question.
Do we have the same complications with the other Densron, with the Densron Extra, or is this the only advantage is the easy of injection?
They claim it has less emulsification because of the physical properties of the Densron Extra. They claim it, but I haven't seen it. I have to follow it for a long time. Okay. But it's easier to put it in and take it out. So that's an advantage.
Okay, great. Thank you.
Thank you. I just would like to add something. You are used to use Densron. Are you right, like I think, that Densron is not dangerous? Is not.
I didn't say it's dangerous.
Okay. No, I mean, many people never use Densron for retinal detachment and things like that because it is well known that Densron can be dangerous, etc., etc. And I disagree with it because I consider in my hands that Densron is very useful in some particular cases, and I would like to get your point of view.
I used Oxan HD. I had some reactions and emulsification, but Densron, it seems better a little bit.
Yeah, I agree.
Thank you.
You have a question, Rahar? Yes.
Heavy silicone oil are the same things that I think we were using Oxane HD. We had adhesion of the globules to the retina, which we found very difficult to take off. But what I wanted to ask you was, you said that you have an air-filled eye when you do your fluid-air exchange, and then you go into the anterior chamber to do a washout. So when you've got an air-filled eye under positive pressure and you make an opening with a paracentesis in the anterior chamber, how do you prevent immediate globe collapse and everything coming out?
That's a good
AC collapse, sorry, not globe collapse.
I just switch off the infusion line, and the water will fall down to the posterior pole.
So you have hypotony then? If you
No, because you're injecting at the same time in the anterior chamber immediately. With your foot pedal, we have 2 hands and 2 feet. So with my foot pedal, when I'm coming into the anterior chamber, when I'm about to enter into the anterior chamber, just before, I switch off the infusion line, I get in with an anterior chamber needle, and I inject my BSS to push away these bubbles that will fall down to the posterior pole. And again, I switch on my infusion line, and I make a fluid air exchange again to clean my posterior pole.
Will they fall in a phakic eye or a pseudophakic eye as well?
For phakic eyes, I say that normally I don't have any problem. I mean, it's going away too, Zonul are not so...
Because the issue is with oil emulsifiers, it comes into the anterior chamber even when you've got a structure dividing anterior and posterior segments.
Just one point about that. I need to publish this because I'm digging in this point actually, but definitely with silicone and Densron, I have my statistics and I have statistics of my former associate, Professor Lieber, who stopped working, and definitely I don't have glaucoma problems, okay? Because of one thing, I'm cleaning the anterior chamber. Because what is doing your silicone oil, Densron or light silicone oil, it's always the same problem. It's coming to the periphery, to your trabeculum, and because of the intraocular pressure, this silicone oil is pushed into your trabeculum. Try it with pastas you put in a tummy, okay, and you push on it. It will be blocked inside. It's the same with silicone oil. If you directly wash your anterior chamber from silicone oil bubbles or Densron bubbles, it will be good.
Thank
So
My
the-
wife is a glaucoma specialist. She will tell me if I come back home with glaucoma cases.
So we have better use 2 hands and 2 feet at the same time. I think we should be
Yes,
moving
quick
on.
comment about ochriplasmin.
Yeah.
The question is how many of us would prefer ochriplasmin if we require it for our eyes, specifically knowing that it's unpredictable, transient vision loss. We use the word, but that's not transient. 3 patients in the original study did not improve back to the normal visual acuity for a year. So I think we need to balance out when we try to spread the message, and whether you would prefer if it's your eye. That's my question.
Depends
you don't need
if
to
I
answer
get
that.
it for free, and I'm old, I'm 90, maybe I would think about it.
Sure.
So,
And a quick point about Thanos scraper. I think once you see the intraoperative OCT image with the Thanos scraper and how much pressure that ultimately gives to the sensory and RPE, one can argue that it works in my hand because I'm experienced, and I agree with that. But I think the important message is that fellows, when they try to start using the peel technique with scraper, they use unnecessarily excessive pressure, and that really leads to a lot of damage. So I think it's important to spread the balanced view on that.
thank you.
Just one thing. I believe that ochriplasmin, it's a treatment that, of course, there is not clear results. And maybe the indication is not exactly the same, because when you have a macular traction, if you are a surgeon, sometimes you try to wait till the vision goes down. And sometimes in vitro, when you put ochriplasmin, even you are earlier, even the vision has a very good vision, maybe because it's recommended less than 0.8 visual acuity. So sometimes I believe that it's a very conflict issue, because it's not clear. It's not clear at all, and there are a lot of little things that maybe can make the treatment was good or not.
Quite convinced that it would work almost similar. May not be exactly similar.
Well,
So it's all about PVD separation process.
Yes, indeed, there are some difficulties when you have to try to see if it's only a vitromacular adhesion or if it's a vitromacular traction with metamorphopsia and these things. So sometimes it's difficult to know, because to evaluate all the patients in the same way.
And the point is whether you would prefer it for your eye, and I know most of the people, they know the answer, so just wanted to raise that issue.
Yeah. So I think that if we have to go way to this premacular bursa with a needle and inject something, I'd rather do a vitrectomy and finish it off with the 25, 27, and that's it. So now the ILM inverted flap technique has been a game changer, and we have the Navroki family, Jersey. Sofia, and they have been promoting and insisting on the thing, and they proved to be right. The inverted flap technique has been a game changer in macular hole surgery. So I think we'll keep having some innovations and alteration as we go, and different thoughts of how to do it as well. Sofia will share with us why did she choose the inverted ILM flap technique.
Thank you very much, Ihab. This is the original inverted ILM flap technique, in which you see that the ILM was peeled from both sides of the macula. And in many meetings, maybe it would be enough to tell you that the president of the society invented this technique to convince you to do the inverted ILM flap technique. But here the people are more open-minded and more curious. So me and the colleagues from the inverted team have to go on with the presentation to convince you that the technique is maybe better than the classical one. The first argument would be that size does really matter. And if you see at our results, we always tell that we have almost 100% of success with macular hole surgery. But we must consider that in large macular holes, in those very complicated cases, the result rate is much lower, about 80%, and there are additional 20% of eyes in which the macular hole is flat closed, as you see on the lower OCT image. These are the results of the original study. This was a prospective study published in Ophthalmology in 2010 by our group, in which we confirmed that not only the macular hole closure rate is higher with the inverted ILM flap technique, but also the visual acuity is statistically significant better in the eyes operated with this technique. Here you can see an example of a patient who was denied for 11 years macular hole surgery. He was discouraged from that because he was treated like a case which has no future, no closure chances. And she was treated after those 11 documented years with the inverted ILM flap technique. And you can see that the hole closed and visual acuity improved very much. Also, the biggest macular hole study up to date, the EVR's macular hole study stated that the inverted ILM flap technique improves anatomy and also visual acuity. The next argument, published by our group but also by others, confirms that it's the ideal technique for other difficult cases, the cases of high myopic macular holes, in which it has also the advantage of closure of the macular holes and of improving the visual acuity and the fovea contour. This technique is also useful, and that's the third advantage, in closure of macular holes coexisting with retinal detachment. Some modifications of this technique arise during time. We'll present them in a moment, but you must consider that with each technique, with ILM peeling, there is some risk of creation of paracentral full-thickness macular defects or of nerve fiber layer defects. This can be reduced by a modification of the original inverted flap technique. You can see here on the video that the ILM is inverted and peeled only from the temporal side of the macula and inverted upside down. We called this modification the temporal inverted ILM flap technique. We published it originally in Retina, but you see that another groups from all over the world published also their opinion on this technique. Another pro was published by Hayashi and co-workers, and that's a very interesting advantage, I would tell you, because he thinks that this technique brings us to earlier anatomical and functional improvement when compared to traditional vitrectomy with ILM peeling. We were taught that there are 5 closure types: the U-type closure, V-type closure, irregular, and flat closed, and of course flat open. With the inverted ILM flap technique, we observed a new closure type that we called flap closure, and we think that this flap closure occurs in those most difficult cases that would normally remain open and would remain failures after traditional techniques. You can see how the hole closes with this only inverted ILM flap. On your left side, you can see the images, and in the first week post-operatively, you can see it with the red star, marked with the red star, that there is only the inverted ILM flap covering the macular hole. But in the next weeks and months, there is some tissue reproliferation or maybe only reapproximation of tissue, but surely you can see 1 year after surgery that the structure of the retina is almost normal. Now coming to repeated surgeries, Morizan and co-workers published a very interesting paper telling how to deal with failures after complete ILM peeling. He took a small flap of the ILM paracentral flap and transferred it onto the macular hole, and that was a great success. And Tamer Mahmoud went even further. I hope he will present it to us today afternoon, but he presented it for the first time in veil vitrectomy this year. He made a full thickness retina transplant, not only ILM, but the whole retina transplant, and he amazed us all while he achieved the closure of the macular hole and improvement in visual acuity. We also made a study on repeated surgeries with the inverted ILM flap technique. Here you can see an example of closure of such a macular hole. We compared 32 eyes reoperated with the inverted ILM flap technique to 11 eyes reoperated with whole edges massage, and confirmed that the closure rate and visual acuity was better in the inverted ILM flap cases. Just to the end, some technical details. We used always membrane blue to stain the ILM. In this technique, there were some reports of toxicity of the ICG, and our standard is using air. In my opinion, there is no use of long-acting gases, as the most macular holes close in the first hours or days after surgery. Here you can see the results before and after the surgery on the slide. What's also very important is that when you inject the gas into the eye, you should very carefully remove all remaining fluid, just to be sure that the flap does not invert to the other side. So please take your time and spend your time on removing the fluid very, very carefully. In some rare cases, for repeated surgery or for patients who cannot maintain face-down positioning, as for example after a tracheotomy, it is possible to also make the inverted ILM flap technique with the use of silicone oil. Also in those cases, you should look very carefully on the position of the flap, and then also during fluid removal from the eye, you should be careful that the flap does not invert. Repositioning of the flap is still possible under silicone oil. When the primary surgeon already removed the ILM from many sides, it's still possible to make the inverted ILM flap with the rest of it, for example, with a nasal flap. So, to conclude with, the inverted ILM flap was proven by a prospective study to be successful and improving anatomical and functional results for large, long-standing macular holes, and also for macular holes in high myopia, also with retinal detachment. The temporal inverted ILM flap technique is an expansion that results in less retinal nerve fiber layer defects. This technique brings also earlier anatomical and functional improvement. The flap closure allows us to achieve closure in most difficult cases, and repeated surgery with the inverted ILM flap technique is less invasive when comparing to classical ones. So I would like to invite you to join the inverted team.
We need more of those hats, Sophia. You know,
We have them.